Bismillah ar-Rahman ar-Rahim. I would like to thank the Saudi Dental Society for their kind invitation. Our topic today is the analgesics and antibiotics and endodontics. It's a debatable topic, and it's not only related to endo because the other dental field have the same problem in the way how the prescription are running in the clinic. But let's start as a simple way. Why we do the endo from the beginning, or whatever the purpose that we are running to do the endo. First of all, we want to remove and reduce the bacteria. We cannot say 100% elimination because we are trying to achieve that goal with the irrigation and the cleaning and shaping, and that purpose will give us the chance to save the teeth. So it's what we call the tooth retention. And this is the two main goals for the endo. To achieve that purpose, we have to control the case, either from the pain or the infection. And this will lead us, to one big dilemma in the endo field, which is the success and the category of the survival, or we can say it's failure. Now, this balance is not all of the time is equal because the endo literature, it's a vague and wide literature. The problem with the literature that we have in the endo, that the criteria, it's different from one to another type, and the clinicians who are running those studies are different in the way how they are a student, intern, or it's a specialist or a postgrad. All of these criteria are affecting the outcome in a way that it can be increasing or decreasing the success, the way how it's managed. So the idea from this slide is that the endo is successful, even though there is some paper it's different from the way how it looked like, because the endo field themselves, they are restricting the design of the methodology by adding sometimes categories in the middle of the timeline between the success and the failure, like the survival. For example, if you have a patient who comes to your clinic with the symptoms of pain, and there is percussion and tender to percussion and palpation, and you might have also a sinus tract, and there is a lesion. Now, if you treat that patient and all of the sinus symptoms disappeared and the sinus tract also resolved, but still the lesion there, it will not disappear in one day because the process that it created that lesion, it took some time. So it will need also the same time to heal. Yes, it will not be the same length, it will be shorter, but we're talking about 6 months to 1 year, that's almost like 70% of the resolution, until 2 years that you might have the complete resolution. Now, do I consider all of this failure? No. That's why they put it under the category of the survival. But even though, it's still a successful treatment because I resolved the sinus symptom of the patient. So by saying that, we need the evidence base, the evidence-based dentistry that's controlling our clinic and how we are managing the clinic. All of this quality of the evidence base with the experience of the clinician will give the quality for the patient and the good service. Any of these circles to be removed from this equation, then we have a malpractice, because running a clinic without an updated knowledge, or running a clinic with no experience in the way how you are taking workshops or whatever, or you are trying on a patient something which is you haven't done before, it will give the patient a bad quality treatment. And this is what will lead us to have this nightmare. The patient's running to your clinic and he's in pain at that time, the endo pain. It's heavy pain that it doesn't make the patient sleep, he will wait out your door till you open the clinic. He cannot do anything all his day till you solve this problem. We deal with this every day in our clinic. So we have a loaded clinic with many patients are waiting, and someone will come to you as an emergency. You want to serve him, but you don't have the time. The way how it's done is just to give the analgesics or the antibiotics and just go home, and then you'll find another spot for him, maybe 2 or 3 days in your clinic. Now, I will not say that no one will do that, but this is wrong. The right way, okay, just you will find another clinic and just give him anesthesia and let him wait. You will find some way, okay, to do a pulpitis, or just to relieve the pain inside the tooth, okay, to drain a pus. And then you can give the prescription, okay, according to the case. But just giving the patient a load of medications and just let him go, that's what created the problem, what we call the bacterial resistance, to what we have nowadays in what we look in the coming slides. Now, the pain, it doesn't come by itself. There is a reason, and even the pus to be started, there is a reason for the same thing. Starting all from a bacteria, that's coming to the first slide we talk about, is to resolve and remove the bacteria. So the bacteria itself, okay, can cause a tissue damage inside the pulp and outside the pulp. With the physical property and the physical cleaning and shaping, with the chemicals that we are using in the sodium hypochlorite, all of this one will cause an immune response and will go and it will do a tissue damage. And this eventually will create an inflammation outside the tooth. And let's make it in a simple way. The infection is inside the root canal. What's outside the root canal is an inflammation. So this radiolucency is an inflammation. It's a response of the body, the immune of the body, to the bacterial insult and byproduct. And with this one, the body starts to defend itself with the chemical mediators, and that one of it that will produce the pain and the way how the swelling, if that immune system is dropping and gaining again. A tooth like that, with a radiolucency that you will see most of the time in your x-ray. It's not an easy process, it's a complicated process. And you can see from this diagram that we have the two systems which is running in the immune system, the innate and the adaptive system, are trying to protect the body from the bacteria and the bacterial byproduct. What's inside the root canal is the infection. What's outside is the reaction of the infection, is the inflammation, which is the radiolucency, by the vasodilation and the chemical mediators, and all of this one is to trying to protect the body. Any break in that cycle, it will affect the immune system. It could be by the patient medical condition or because of the aggressiveness of the bacteria. But even though we should first treat the infection, which is inside the root canal. It's not outside the root canal. If it's outside the root canal, then whatever you're doing inside the canal, it doesn't make any difference. Unless if I'm going to do surgery for all of my cases. But you can see that most of the cases are resolved with doing the conventional root canal without going for surgery for some extensive or special cases. When we talk about the analgesics, it's a blessing to have it, but abusing them, it could cause some disasters for the patient for taking it a long time with no treatment. One of the good things about the analgesics nowadays, it's not only for the pain after the treatment, but it could also give me an advantage before the treatment, which we call the pre-treatment, that give the patient load of the analgesics before the visit. And this will minimize the inter-appointment and the post-appointment pain. Also, it might also reduce the flare-up. Now, the downside from this one, a patient who will come to you first time to your clinic and you don't know what's the case, and he took analgesics, it will mask the sign and symptoms and will not give you the correct diagnosis for some cases. Now, when we talk about the recommendation, this is just a famous graph that you will find it in most of the literature on the textbooks. It's a flexible way how to prescribe the analgesics. Two tracks. You need to know the medical status of the patient. Can he tolerate the NSAIDs, or he cannot tolerate the NSAIDs like the ibuprofen? For example, the patient is taking an anticoagulant, so they cannot take the ibuprofen because it's in counteract with the anticoagulant. So the preference for them is the other side, like the paracetamol. So when we talk to or to explain the way how we can make the strategy for the patient who can't tolerate the ibuprofen, the ideal choice or the first choice is the 200 to 400 milligram of ibuprofen. This is for the mild pain. And for the moderate pain, we can go with absolute only ibuprofen with 400 to 600 milligram, or to combine the ibuprofen with the acetaminophen or paracetamol, and 400 to 600 of ibuprofen, or 500 to 1000 from the paracetamol. We might go for the severe pain, and this will be a big dose of ibuprofen that goes to 800 ibuprofen plus 1000 of paracetamol. Now, combining this big is too much for the patient. So you can divide it by 2 to 3 hours, giving one type, then give the other type after 2 to 3 hours. If the patient cannot tolerate the paracetamol, then we can go with the the patient cannot tolerate the ibuprofen, then we go with the paracetamol as the first choice by 500 to 1000, or with the moderate pain going with the 1000 plus codeine. There is some product in the market that have this combination. The problem is the severe pain with the oxycodone and other types. Some of them they are like a control drugs, so they need a special or controlled prescription, and you cannot find it anywhere. Now, the updated part about the analgesics is the combining the analgesics. We were saying it's a long time to combine the ibuprofen and the acetaminophen or the paracetamol, but there is an evidence, because based on what Moore and others said, this is a systematic review, that the combining the ibuprofen and the acetaminophen have the highest association with the treatment benefits for the pain control efficiency. If you add the oxycodone or the codone products, it will not make a difference in how the pain control efficiency is, but it will extend the length of the pain control. So you still have the control by giving the ibuprofen and acetaminophen. Now, the good thing also, because of like these type of papers, the FDA approved the manufacturing of drugs that could be a pill that have both of these types of drugs. And you can just only Google it, that you'd say ibuprofen plus paracetamol or acetaminophen, and you can see many products now, and nowadays is a one pill that have both the benefits from these two medications. Going for the abuse part is the antibiotics. If you look at the history, this is a striking paper. It was by Finland in 1951. And in the striking part about this paper, that at that time in 1951, it was a big explosion for the discovery of the antibiotics. And even though they discover a resistance for penicillin, which is the main product that we are using in the dental field. And what makes it worse, making this worse, is the gap between the last time that we have a class discovery of the antibiotics was almost 40 years back. So we have a big gap in the discovery of new classes of antibiotics. And what makes it even worse that the timeline from the start that we have a discovery of a new antibiotics till we have a resistance, it's about 5 to 10 years since the 1930s till nowadays. And it becomes worse and worse because we don't have any classes anymore to antibiotics that's discovered. So the situation is really bad, and we are not learning from the history. And now we're almost like a century, and we are still doing worse than before. If you look to the status, in general, that was a medical status in all these specialties. Among the dentists, it's it's 10% among the medical field is the dentist. 10%. Even it looks like a simple percent, but really we are part of this problem. And if you think nowadays with the growing number of the dental practitioners, how much is the 10% and how much they are affecting this bacterial resistance. And this is an ad by the NHS in the UK. Now, this is toward the public, and they are just making an educational part for the public, that saying that taking the antibiotics, okay, if you don't need them, okay, it puts your family at risk, and take the doctor advice. Now, this one should be made for the physician, not for the public, because the public are taking the instructions and the prescription from the physician. So it should be toward educating the physician, because if you don't know the treatment, you just only give the antibiotics, that's a malpractice. If you look for the indication of the antibiotics, okay, in our field, and these only the things or the sign and symptoms that the patient has that you can give and prescribe antibiotics: fever, malaise, lymphadenopathy, trismus, increased swelling, and cellulitis. If you look to all of this one, it's a break in the immune system. It's not a pulpitis, it's not a pain, okay? It's a cause because of the swelling that start to progress in the patient body by the fever and the malaise and the lymph nodes, okay? And then we might have a trismus because of the swelling and its pressure on the muscles, and we have increased swelling that it might lead to a cellulitis. Osteomyelitis is one indication, and the last thing is the immunocompromised patient, which is the patient out of the normal in their immune system. The condition not requiring antibiotics in endodontics are pain without sign and symptoms, like symptomatic irreversible pulpitis, symptomatic apical periodontitis, teeth with a necrotic pulp and radiolucency doesn't require antibiotics, teeth with a sinus tract that already has a pus discharge, and localized fluctuant swelling that it's in the buccal vestibule. That means already there is a pus discharge. Unless if there is a break in the immune system, you cannot just go and prescribe antibiotics. Again, okay, the only way from all of this, okay, to prescribe antibiotics is the acute apical abscess in medically compromised patients. Not all of them, specific categories. Acute apical abscess with systemic involvement and progressive infection, that you might have a patient who comes as a flare-up, and then you might go with the swelling, and then you can go with the antibiotics. This is the big issue here. Does the lesion require antibiotics? Does the antibiotics go to the periapical lesion? The answer is no. There is no microcirculation there. It's a necrotic zone. It's only a defense mechanism of the inflammation of the body. The antibiotics will just pass by through the bloodstream. It will not go inside the tooth and find the bacteria to kill it. There is no access at that part. So it's only abusing the antibiotics by giving it to a lesion, unless if the body system immune response is dropping down, then you give the antibiotics. What's the efficiency? And because of the abuse of that antibiotics, the antibiotics now starting to be going from lower to higher first choices. This is a good study by Baumgartner, and this is in 2003. At that time, okay, the first choice was the penicillin VK. and you can see the number on the bars. That means the percentage of how much the antibiotics can kill of the bacteria. Nowadays, okay, the first choice is the amoxicillin, and it's still high, 91%. The second choice, or the backup, if the amoxicillin didn't work, was the amoxicillin clavulanic acid, which is 100% can kill the bacteria. Do I have to go from the first time with the amoxicillin clavulanic acid? No, you need a backup. So you go with the least, with the amoxicillin. And we'll talk about how many days then you can switch to the amoxicillin clavulanic acid. Another update also is the clindamycin, which now becoming switched by another type, but still can be used. Clindamycin has a 96% of the efficiency. Clarithromycin and azithromycin, it's 89%. Now the least and the worst is the metronidazole, and should not be prescribed because it affects the patient and has many side effects, and it's the least antibacterial resistance, that it has more of the resistance in the metronidazole. It's 45%. Yes, you might add the metronidazole to the amoxicillin and you will have 100%, but I don't need that 100%. It's just an extra abuse of the antibiotics. So when you go to the first choice, it will be the amoxicillin. If it didn't work, okay, or we need to switch it, then you go for the amoxicillin clavulanic acid. If the patient has penicillin allergy, then you will go with the clindamycin. But nowadays, the choices, and we will say the support that we have is this azithromycin. But if we cannot tolerate the azithromycin, still clindamycin, our first choice in the penicillin allergic patient. Now, how long we can use the antibiotics? This is a big issue also. We don't have in the dentistry called a complete course, especially in the endo. I'm talking about the endo field, okay? So we don't have a complete course. They are claiming that the complete course, that if I stop the antibiotics and there is still a swelling, does it rebound? That means it will go back to grow again. We don't have a rebound in the endo field. We don't have a rebound in the endo field because our endo infection is inside the tooth. If the patient comes to you with a swelling and I give him an antibiotics and 2-3 days, okay, and the swelling start to go down, at that point you can stop the antibiotics, because you are now giving the support and giving the lead for the immune system to take the in charge of the body immune. It's not the antibiotic now is working. The antibiotics after that time, it's just only going through the bloodstream and it's not doing anything. When we can change the antibiotics, if let's say I give the antibiotics now and 2 to 3 days, the case becomes worse and it didn't go down, then I can switch to a higher dose. So if I prescribe amoxicillin, I need 48 hours to 72 hours. If the swelling is not stopped and it becomes worse, then I can switch to the amoxicillin clavulanic acid. Now, the recommendation that we have for the antibiotics, this is in general, but we're talking about the amoxicillin that we have 500 milligram for every 8 hours. And the first choice, okay, for the penicillin allergic nowadays, especially with the endo recommendation, is the azithromycin, which is the same amount of the clarithromycin, which is 250 milligram every 12 hours. If you're going with the amoxicillin with the clavulanic acid, it will be 875 milligram for 12 hours or 1 gram. Now, how you can play with the antibiotics that can serve you in a way that you can help the patient without giving a higher dose from the beginning or giving a higher amount or type of the antibiotics. If the patient comes to your clinic and he's already having a swelling, okay, then you can make, let's say, for example, the amoxicillin. You can make the first dose, okay, to double it, double the first dose. So instead of 500, you give him 1,000. That means 2 tablets. But the maintenance dose, that is second and third dose, will be 500. The same thing if the patient allergic, okay, then you might go with the loading dose. You cannot do a double dose with the amoxicillin clavinic acid because it's a higher dose from the beginning. This is the updated part about the penicillin allergic patient. The first choice now is azithromycin with the 250 milligram, and for the loading dose is 500. They found the clindamycin have some problem with the cholesterolitis, that it could be fatal for the patient. But even though the patient has penicillin allergy or it's cannot tolerate the azithromycin, you can still use the clindamycin. There is some exceptional case. All of what we had said before, it's a regular patient with no medical problems. But there's some cases that we can give antibiotics for certain reasons, starting by dental trauma. Not all dental trauma, only the avulsion. The avulsion is the one that require, a doxycycline of 100 milligram. And this is the recommendation by the International Association of Dental Traumatology. Cardiac patient, not all cardiac patients, but this one is different because this is need a prophylaxis, just for the cases with the prostatic cardiac valve, previous endocarditis, infective endocarditis, congenital heart disease, and cardiac transplant. The prophylaxis, it's recommended by the American Heart Association, and this is the prophylaxis that can be used with most of the immunocompromised patients. That's as before the treatment, 1 hour. Is the amoxicillin 2 gram, or you can go with the azithromycin or clindamycin 600 or 500 milligram before 1 hour the treatment. Immunocompromised patient, and I'm trying to be very concise because of the time of the lecture, but if you need more about the detail, you can go to the my YouTube channel. There is the lecture of the medically compromised patient in the dental practice. We have the leukemia. Not all type of leukemia, but you need to know the white blood cell count for those patients. If it's below 2,000, then it will need a prophylaxis. HIV, not all of them, but if you have the count of the CD4, then you might go, if it's low, then you might need a prophylaxis. End-stage renal disease, dialysis, not all the renal disease, only the patients who are doing dialysis and they have implanted device in their hand, then they need a prophylaxis before the treatment. Uncontrolled diabetes, not all the diabetic patient, but the patient that we are requiring is the uncontrolled is the HbA1c. They have it 8 and 9 above. Those are prone to infection, so they might need also an antibiotic coverage. Chemotherapy and radiation. Most of these patients will not come to you during the treatment. Mostly they will come to you before they start radiation. Very exceptional, rare that you have this patient, but you need to consult with their physician to know exactly what type they are taking and the route of their treatment. Patients who are doing a transplant, kidney or liver, they are taking immunosuppressive drugs. So we need to keep that working, and this is suppressing the immune system, so they will need an antibiotic prophylaxis before the treatment. Now, for all of this, we still, as an endodontist, a very safe practice. We can see it from this chart. The endo procedure is only up to 20%. You can imagine that the wedge placement is higher bacteremic than the endo. I would like to thank all of you for the attendance, and I wish in the future we will meet in person. Please be safe and take care, and be always updated. You can use your cell phone applications. Nowadays, it's a blessing that we have everything on the internet, and there is no reason for anyone that cannot find an answer for anything. I would be happy or glad if anyone wants anything. These are my contact info. Thank you very much.